Good afternoon, everybody, and on behalf of Wendy Spearman, myself, Mark Sondrop, welcome to the last COVID Department of Medicine ECHO meeting for the year. We would just like to again acknowledge our gratitude to the University of New Mexico and Project ECHO for extending their license to us earlier this year to hold these Zoom meetings hosted by the Department of Medicine, the University of Cape Town Groote Schuur Hospital. Again, we're also very grateful to the support we've had from Sahana Rangel from the Department of Medicine and Cheryl from the Gastroenterology Foundation of South Africa. We're handing over to Graham Mankies, your host for the afternoon, for the last time this year, who will take us through the agenda of today, which really is a very timely wrap-up of the treatment of COVID-19 and the evidence we've accumulated to date. Graham, over to yourself.
Great. Thanks very much, Mark and Wendy. So as you say, this is our final COVID-19 webinar for 2020. It's also our 29th webinar that we've hosted over the last 8 months. And before we get into the talks, just to say that we will have a few slides at the end to really reflect on the journey that we've been through over the last 8 months with these webinars and thank one or two people. So if you are able to stay on for that, we'd appreciate. So the next thing on the agenda that we're going to move on to is a short presentation from Lara Farrell. Lara is the director of the Knowledge Translation Unit. They've been producing the PAC guidelines for many years and have developed PAC guidelines specifically focused on COVID-19 for healthcare workers, and it's been a huge support for healthcare workers in the health system, and have recently updated those, and Laura's going to give us some background about that. So over to you, Laura. Thanks very much.
Thanks, Graham, and hello, everyone. So just to go to the next slide, so I can briefly explain what PAC is about to those of you who might not have encountered it before. Next slide, please, Mark. So PAC has been in progress for about 20 years now, and it stands for the Practical Approach to Care Kit. It's a health system strengthening intervention, which essentially comprises clinical decision support, which is comprehensive, follows a life course approach. So we have a very mature offering for adults, but we also have one for children and adolescents in development, and is implemented through evidence-based implementation strategies. It's been consistently evaluated in some large trials, which has shown modest but consistent improvements in a range of behaviors for primary care, both in South Africa and Brazil. And it's scaled up within the Western Cape, where it's known as PAC, in the rest of the country, where it's known as adult primary care, and in Brazil, where it's known as PAC, and Nigeria, and in Ethiopia, where it's known as Ethiopian Primary Healthcare Clinical Guidance. And if you want to know more about it, there's some links to some resources if you wish to read more about that. So just to show you what we've been doing during the COVID period. Next slide, please, Mark. Is we have obviously expanded our primary care content. We update PAC for the Western Cape every year, the adult content. And we produced our first version for healthcare clinicians in primary care facilities on the 6th of March. And we released our 5th version on Friday. It swelled from 4 pages to 38. And it includes a comprehensive approach to how to screen, test, and manage patients in primary care with COVID. Importantly, this year has seen 2 or 3 very interesting innovations. For our unit, we've done our first inpatient content with many of you in the department. We've expanded our community content significantly and are responsible for many of the posters you see around. And we've also moved a lot of our training into the online space. Our community content is also available in a zero-rated community platform called CoronaWise for members of the public. So next slide. So this is really not to go into detail, but just to highlight what is in these resources so that you're able to refer to them if you wish to, or refer colleagues to them. So the primary care content, which came out on Friday, is aligned with the NICD version 5 guidance, and it covers, next slide. So 38-page document. It covers screening of patients as they come into the facility. So right from when they enter the facility grounds, includes a serious assessment for TB, because we've been very concerned by the drop in TB case detection during the first wave. It includes assessment for referral and pre-referral management and bloods. So you may notice that more patients are being referred from primary care with HbA1cs and creatinines pooled already. The community management of non-severe cases, and contact management of people who have been in touch with that index case. It also includes a first approach to long COVID, which I thought I'd just put the pages up here because we discussed it last week on the ECHO meeting. So recognizing that most of those people will be presenting to primary healthcare with ongoing symptoms, and that TB exclusion is going to be very important to people with persistent cough. There's an approach to healthcare worker exposure, palliative and end-of-life care, and management of deceased patients. So that's the primary care guidance, and that's complemented by the inpatient content. And we've released our second version of that on Friday, and that's a 28-page piece of content. Next slide. Which importantly does not include critical care and ICU management. So it's really targeting those people who are perhaps working on COVID wards and who would otherwise be working outside their scope of practice. So it's not really this, I suppose, audience, but it's for people working in district hospitals, for people who may be working in field settings, and for people who are working outside, specialists who are having to now manage patients. And we thought we'd put it out just before, as this wave 2 hit, just because we were aware that many people are going to be trying to take some leave over this time. And so many doctors might find themselves in the position of having to manage patients with very little support. So it includes an assessment of the person on admission, including determining which level of care they need, which is informed both by a clinical assessment as well as a frailty assessment. Includes extensive information on the co-management of diabetes, because that has been a particular challenge. And I particularly want to just thank Joel Dave for his incredible work he's done with us on that. It includes a lot of content on how to practice safely, on healthcare worker exposure, and palliative and end-of-life care, as well as management of deceased patients. So just to show you what PAC content looks like, if you're not familiar with it. Next slide. So it's aligned with the version 5 of the NICD guidance and the EML. And so that was a bit of a tricky alignment, the EML alignment, because it's not, the hospital EML doesn't contain very detailed algorithms and recommendations for all aspects of inpatient care. So this shows you what the pages look like. We have a combination of 2 types of format for our content. The first is some simple algorithms, which will take you, for example, how to manage a person exposed or raised glucose, etc. And then we have some tables which provide handy checklists for when you're assessing or reviewing patients with COVID. Next slide. And then I just want to, so these are some of the references that we've used for the inpatient content and the alignment with the different circulars. Keeping on top of the circulars is quite a job, as I'm sure you will know. But the main reason I wanted to include this slide is I just want to acknowledge and thank people in the department who've really contributed very significantly to this content. And they've done it under extraordinary circumstances when they've been managing full clinical caseloads and been working night shifts and etc. So just to say, really, we really appreciate that. And also thank you for your patience in bearing with us in terms of navigating these very difficult tensions between what is approved in policy guidance and what is emerging as best practice. Next slide. So just where to find these resources if they haven't arrived in your inbox instead. So we've got our website. If you just Google Knowledge Translation Unit, the first thing that will come up is the Kerala Transfer University. So it's not that, it's the Knowledge Translation Unit at the University of Cape Town. And on our homepage, you'll see a tab which takes us to all the coronavirus resources, which includes all the health guidance. There is a version of both the primary care guidance and the inpatient content that is APC aligned, that is suitable for use outside of the Western Cape. So if anyone from outside the province is on this call, that is available. The inpatient content will go up later today or tomorrow because it was signed off last night. There is free online training, and we've had almost 8,500 clinicians complete one of our trainings this year. And the latest training, which is going to focus on TB and COVID integration, will go live later this week. So that is also available. And there are many public sector resources and sector-wide resources. So those are all in one place. And we do keep this updated on a daily basis. So that's it from me. But just to say really a big thank you to many in the department who've contributed to this work over the past year.
Okay. Thanks very much, Laura, for the input and for the work that you and your teams have been doing to support healthcare workers in the fight to manage patients in the face of this epidemic. So, and thanks for the input. So we're going to move on to our next, our main talk for this afternoon, which is a double header on the treatment of COVID-19, a review of the current evidence in the literature, really looking at studies that have been done over the last 9 months on the treatment of the condition. And the two speakers are both colleagues from the Department of Medicine. Sean Wasserman. Sean is an associate professor in the Division of Infectious Diseases and HIV Medicine, has particular research interests in drug-resistant TB, pneumocystis pneumonia, Staphylococcus aureus infections, as well as antibiotic stewardship. And the second speaker is Dr. Linda Baloko. Linda is a specialist physician and is now undertaking his PhD focusing on questions in HIV-associated TB, and was recently awarded the Professor Bongani Mayosi Netcare Clinical PhD Scholarship. Both Sean and Linda have been working in the COVID wards at Groote Hospital over the last few months, so have really first-hand experience of managing COVID-19, and will bring that to bear in the talk today, as well as their review of the literature. So I think Sean is first up, and over to you, Sean.
Thanks very much, Graham. Hi, everyone. On behalf of myself and Linda, thanks very much for inviting us to speak at this last COVID session of the year, which has been invaluable to many of us. So this is actually a combined talk, and it's integrated. I'm going to start off first and then hand over to Linda, and then he'll hand over back to me to end off. So when I was thinking about this talk a few weeks ago, I was in a kind of space of misplaced optimism, or maybe wishful thinking, and thought that I might have to kind of justify the reason for presenting this review of current evidence. We had just heard reports of very effective vaccines. We were kind of back to almost normal life. But this was seriously misplaced because we now, as Andrea has shown, are in the midst of a major resurgence. And that's shown us that we need to provide immediate quality care to our patients who are currently in the ward. And that's the first kind of immediate reason why it's important to review the literature right now for evidence-based management. But also it's very likely that we'll be living with COVID for a long time. And it's even possible that there may be post-pandemic transmission. The duration and durability of protection after natural infection and after vaccines is unknown and might not be complete. It's going to take very long for vaccines to get rolled out, especially in South Africa. And as we've learned from these furry creatures, minks in Denmark, it's very possible that this virus can mutate and spill back over into humans. But the third reason is a very important reason, and that is that there's been widespread use of off-label and unproven therapies for COVID, and that's been a kind of defining feature of this pandemic. And this practice is at best futile, and at worst, as we've seen with hydrochloroquine, harmful. And it's also affected the ability to do clinical trials to identify the safest and most effective therapies, because patients are reluctant to enroll in clinical trials if this has been used as standard of care, but is unproven. And so in that context, it's really important to review the latest evidence-based management to enable the best care of our patients. And that's what we hope to do now. The difficulty is that with this avalanche of publications that's been spoken about a lot, it can be very difficult to keep track of what's new, what's important to read, and to know where to start. And so just to kind of provide context, by the 2nd of November, there were almost 60,000 articles published at a median of over 1,600 a week from January this year. And this is almost 20-fold more publications than the last pandemic that we had, which was the H1N1 influenza pandemic. So there's just been an explosion of publications of varying quality. And by yesterday, there were more than 17,000 publications just on treatment strategies and vaccine development. So we're obviously not going to cover everything in this 30 minutes talk, so we've decided to use a clinical case report as clinicians to identify the key areas that we're going to focus on. And I'm going to start off by presenting that clinical case, which some of you might be familiar with. This is a 73-year-old man, and I've covered his eyes to protect his confidentiality, who doesn't really have a known medical history, but he's known to be obese and does engage in some exercise, which is mainly golf. He takes prophylactic hydrochloroquine, and that isn't for malaria prophylaxis. He also takes aspirin, but no other chronic medication. And he contracted COVID after attending a super spreader event at his workplace. And last month was admitted to hospital with COVID pneumonia and mild hypoxia. So this was his management. On day one, he received, and this is before he got admitted, before he was hypoxic, he received an infusion of a monoclonal antibody cocktail called a Regeneron compound, which targets SARS-CoV-2 directly. On day two, he was admitted to hospital and was given what my colleague Evan Schul calls a nuts and berries protocol of zinc, vitamin D, melatonin, famotidine, which I think is a H2 blocker, and aspirin. And then he subsequently developed hypoxia and was given oxygen plus a remdesivir infusion, dexamethasone, and was also given venous thromboembolism prophylaxis at an unknown dose. And his doctors considered an IL-6 receptor antagonist, tocilizumab. So we're going to base our presentation on this patient's management. Our focus is going to be on treatment for inpatients. So we're not going to speak about outpatients or prevention or vaccines. We're also not going to speak about supportive care because there's not enough time. Linda's going to speak about the most impactful large trials that have been done, the recovery and solidarity trials. And together we'll overview the best evidence-based for direct antivirals and the main ones that have been used, plus and one anti-malarial, the key immune-based therapies, and because it's controversial, venous thromboembolism prophylaxis. And then finally, we'll end off with future directions. We're also not going to cover things like vitamin D and zinc because the biological plausibility for these is at best tenuous, and there really isn't any evidence to support their routine use. So I'm going to hand over to Linda now to take us through the start of the talk.
Thanks, Sean. When it comes to corticosteroids in the management of COVID-19, particularly dexamethasone, the recovery trial, dexamethasone is almost synonymous with the recovery trial. This is an ongoing trial within the National Health Services in the United Kingdom, involving over 175 sites. It's a very simple design trial with patient enrollment done online, minimal data collection, and with data entry and quick randomization done on a very simple, basic online platform. They have a single follow-up of their patients for their outcomes of interest, mortality, and discharge at day 28 of hospitalization. And this was very clear from the results of this trial that patients who were on the dexamethasone arm had marked benefit in terms of mortality reduction at the end of the study. This was particularly pronounced in those participants who were ventilated with up to 35% of those patients achieving a mortality reduction compared to the usual care. Patients who were receiving oxygen also had mortality benefit with over 20% of, with about 20% of those patients achieving a reduction in mortality. John, can you go to the next slide? In terms of their secondary outcomes, more patients were discharged in the dexamethasone arm compared to the usual care. And importantly, these were patients who were ventilated in the ICU setting. Also within this, they show that patients who were not ventilated at study entry, actually this drug prevented, dexamethasone prevented progression to ventilation in these patients with statistical significance in that sub-analysis. Next slide. To date, there's been about 13 trials which have looked at the benefit of corticosteroids in the management of COVID-19, with pooled estimates showing that there's an overall mortality benefit of this drug. What is important to note is that in the recovery trial, this benefit was seen in those who started dexamethasone at more than 7 days after symptom onset, suggesting that there is a pathophysiological mechanism involved with use of dexamethasone. Next slide. In terms of remdesivir, this was by far the most promising antiviral at the beginning of the pandemic, with the World Health Organization Solidarity Trial being the biggest trial to evaluate this drug amongst other repurposed drugs for management of COVID-19. The Solidarity Trial, like the recovery trial, was a very simple design trial with the most minimal inclusion criteria to enter into the study. Again, online platforms with a single follow-up at day 28 and very minimal data that was collected. Unfortunately, this trial did not show any mortality benefit when it comes to prevention of deaths within the remdesivir arm. However, the adaptive COVID-19 treatment trial did show that there was a shorter time to recovery in patients who were on the remdesivir arm. This was subsequently replicated by Spina and colleagues with just under 600 patients, who showed that there was improvement in the clinical status of patients who were randomized to a 5-day course of remdesivir versus 10-day course compared to standard of care. Unfortunately for Wang and colleagues in Wuhan, they had to stop recruitment following the pandemic control, the epidemiological pandemic control in that part of the world, and subsequently were not powered to show any benefit in their primary and secondary analysis. However, they did show numerically that there was improvement in terms of shorter time to clinical improvement in the remdesivir group. Next slide. So in this figure, I just want us to pay attention to the low flow oxygen use. This is a figure that is looking at subgroup mortality analysis in the different trials stratified by oxygen use. If we pay attention to the Solidarity low oxygen use, as well as the ACTT trial low flow oxygen use. Next slide. Then we can see that in actual fact, remdesivir does have a mortality benefit in the lower risk group. This is clearly shown in the ACTT trial with 70% mortality reduction in those who were on low flow oxygen, and is suggested by the Solidarity trial when you look at the lower bounds of the confidence intervals, suggesting that there may be mortality benefit within this subgroup analysis of these patients. Hence, currently, the Solidarity trial is still recruiting within the remdesivir arm to try and improve the precision of these estimates. In terms of time to recovery, we saw that there was much more benefit in the ACT trial in the first 10 days of study entry in terms of symptoms than there was in those patients who entered into the study after 10 days. Some of the problems that led to their Solidarity having almost negative results was that they included quite late disease, with more patients ventilated within the remdesivir arm by chance in that, and duration of symptoms was unknown. So it was difficult to perform analysis around this very important feature of COVID-19. Next slide. So in a low resource country, low resource limited resource country like South Africa, we want to reduce hospital stay to save on the resources. But importantly, we want to improve patient symptoms and reduce progression of disease towards ICU admission. And in those patients who are admitted to ICU, we want to reduce the number of days on mechanical ventilation. And it seems like remdesivir seems to be offering all these effects as demonstrated in the ACTT trial. And then when they adjusted for the use of corticosteroids, it seems that effect of dexamethasone may be additive to that of remdesivir. Subsequently, the FDA in the United States has approved the use of remdesivir for the treatment of COVID-19. And the NIH made recommendations that patients who are admitted to hospital on low flow oxygen, minimal requirements for oxygen support should be on remdesivir with escalation of therapy to include remdesivir plus dexamethasone as the escalation of oxygen support is needed. Next slide, please. Lopinavir return of recommendation is now a drug of historical interest. Many trials have looked at it with over 8,000 patients studied with the pooled estimates showing that there's absolutely no mortality benefit for this drug. So absolutely out of consideration for the management of COVID-19. Next slide. This is true for hydrochloroquine as well, as Sean had alluded to earlier on, that some trials are already showing that there may be harm that is caused by this drug with regards to deaths, clinical worsening of symptoms, as well as ICU, as well as adverse events that are associated with this drug. Many people have prescribed this drug off-label, probably the most investigated drug with no effect in the history of in history. Next slide. Some people have looked at the utility of hydrochloroquine for prevention of progression of disease from mild disease to moderate severe, requiring a hospital admission, or improvement in the severity of symptoms in patients on hydrochloroquine versus control. And none of these effects have been shown to be different between patients who are receiving hydrochloroquine or control. Next slide. And finally, when it comes to hydrochloroquine, two very large studies have looked into prevention of development of disease in patients who have been exposed to positive COVID-19 cases. And none of these studies have shown any benefit or any effect for hydrochloroquine to prevent progression to development of disease. Slide. Interferon beta-1 was the last drug just of recent in October to be removed from the WHO Solidarity trial after showing absolutely no effect in the reduction of initiation of ventilation or mortality benefit. However, there is some data in smaller trials that's showing that inhaled or nebulized interferon beta-1A may be more beneficial than subcutaneous and intravenous interferon beta-1, and the ongoing ACTT trial may possibly include that arm in their study. Next slide. Another drug which was highly publicized to be effective in COVID-19 was azithromycin. However, multiple trials, particularly looking at the Coalition 2 trial in Brazil with just under 400 patients, has shown absolutely no benefit in clinical improvement or their secondary outcome of mortality. We're still waiting for the recovery trial to show us if there's any benefit with larger numbers in that arm of the recovery trial. So currently, the recovery trial is evaluating the effect of colchicine in reducing mortality. This was probably based on a small study that was done in Greece of about 100 patients, which showed that there was a higher survival probability in those participants who received colchicine compared to control. And aspirin has been included based on observational data, largely showing a decreased risk of mechanical ventilation, ICU admission, and mortality in patients who were on aspirin compared to those who weren't. And these are some of the therapies that are currently being evaluated that Sean is going to tell you more about in the next couple of slides. Thanks, Sean.
Thanks, Linda. Okay, so I'm just going to wrap up speaking about those agents that Linda's just mentioned. And I'm going to start off with IL-6 antagonism, which also underwent widespread off-label use. And that was because from early on, there was this observation that severe COVID is associated with elevations in inflammatory markers, including in inflammatory cytokines, and that IL-6 elevation specifically has been associated with mortality in severe COVID. And this triggered widespread use of tocilizumab mainly, which is an IL-6 receptor antagonist. It's a monoclonal antibody, and in some senses even became the standard of care for patients with COVID and hyperinflammatory states. And early on supporting this practice were reports from case series and actually large observational cohorts that there was potentially a mortality benefit from the use of tocilizumab in patients with severe COVID. But the kind of rationale underpinning that is not so strong. When COVID, the pathobiology of COVID is looked at more closely, it seems like, and in fact it's pretty clear, that concentrations of IL-6 in COVID, both patients with severe COVID and critical COVID in the systematic review, compared to other very similar conditions with similar clinical phenotypes like hyperinflammatory ARDS, sepsis, cytokine release syndrome, the IL-6 concentrations in COVID are much, much lower, orders of magnitude lower than these syndromes, which look very similar. And IL-6 blockade has been tested in these syndromes, but actually doesn't work in terms of mortality or clinical benefits. Furthermore, causal relationships with these kinds of approaches are unclear. So is elevation of IL-6 a driver of pathophysiology, pathobiology in COVID? Is it just a marker of widespread inflammation? Or potentially it could be an adaptive response that is helpful to the patient, and antagonizing it might be harmful. Tocilizumab itself may be harmful both directly, and there have been case reports of GIT perforation, but also the big concern is impaired host defenses because of its critical role in inflammation and risk of secondary infection. But very importantly, pursuing this kind of approach, which doesn't have a strong underlying kind of biological rationale, presents an opportunity cost for doing clinical trials for agents that might provide more benefits. And in fact, there have been a number of randomized controlled trials looking at the efficacy of IL-6 antagonism, mainly with using tocilizumab. And none of these 5 trials that have been published have shown any effect on mortality. And the effects on other outcomes like duration of symptoms, duration of hospitalization, mechanical ventilation, except for one, has been inconsistent and unconvincing as well. And so to put this in kind of clinical perspective, in absolute terms, the pooled effect of tocilizumab in these clinical trials resulted in, or is predicted to result in 8 more deaths per 1,000 patients treated. It's quite a wide confidence interval around harm versus benefit. So it ranges from 22 fewer deaths to 51 more. So this is not going to be the effect is going to be, if any, very small, but it may also cause harm. And so as a result of this, US guidelines, major US guidelines, have recommended against the use of tocilizumab because there's this low likelihood of meaningful effect on mortality and in fact on other outcomes. And there's this putative risk of harms with the use of tocilizumab. And the recommendation is that it should only be used in clinical trials. And I think people have slowly moved away from it. So what about convalescent plasma, which is also something that's been spoken about a lot and was identified early on as a potential therapy based on passive transfer of neutralizing antibodies from people that have recovered from COVID that could potentially lead to a reduction in viral amplification and reduction in progression of disease and perhaps mortality. Other effects have also been postulated, which are kind of non-specific but contained within the plasma of COVID survivors. And that could include antibody-dependent cytotoxicity, maybe inhibition of pro-inflammatory pathways. And so convalescent plasma was also used quite widely off-label, especially in the United States with an expanded access program, and in multiple observational studies, and in fact, 2 small randomized controlled trials that were stopped early. And the early evidence from those studies favored the efficacy of convalescent plasma with an observed mortality benefit in these mainly observational studies, of close to 60%, which is very encouraging. In the large expanded access program from the Mayo Clinic, two things kind of stood out. Convalescent plasma therapy was more effective when given early on in the disease course, and the outcome also depended on the dose of neutralizing antibodies that were contained in convalescent plasma that was given. Two randomized controlled trials that have been completed in the last few weeks have been published and have had disappointing results, one from India and one from Argentina. Both enrolled very similar kinds of patients with moderate to severe COVID, both hypoxic, admitted to hospital, given convalescent plasma 1 or 2 doses, very similar primary outcomes of severe disease or death. And neither of these trials showed a mortality benefit. Both had quite wide confidence intervals around harm versus benefit. And I think the take-home message from this is that this is not, in the words of Mark Blockman, a panacea. So there's not very strong evidence for having a large effect, and it should not be used off-label outside of clinical trials. And a smaller effect is potentially possible. And major guideline recommendations are in line with this. So related to convalescent plasma is the use of anti-SARS-CoV monoclonal antibodies. And there are two really front-runner molecules that have now entered phase 3 trials. The one I spoke about earlier, which is a Regeneron molecule, an antibody cocktail that was made from humanized mice and from convalescent patients, that contains 2 antibodies that bind to 2 different sites on the spike RBD. And the major benefit of this is that it can potentially prevent, and it's been shown experimentally to prevent viral escape. So, viral mutations after widespread use of this kind of agent. And the other one is an Eli Lilly compound, which is a monoclonal antibody, just a single one, that binds to the receptor binding domain of the spike protein plus the ACE receptor. And so can potentially block viral entry. But in patients with severe COVID in phase 3 trials, this has been very disappointing. And the 2 trials that were conducted by each of these companies have been stopped. For the Eli Lilly compound, it was stopped because of futility. And for the Regeneron compound, this is the press statement: potential safety signal and an unfavorable risk-benefit profile. A little bit mysterious. The data has been reviewed by the recovery investigators, and they're continuing to randomize patients with severe illness to this. But it does appear to be benefits in patients with less severe disease earlier on. And this has been published for the Eli Lilly compound. And there are ongoing trials looking at this for that patient cohorts for both of these. And so finally, I'm going to discuss therapeutic anticoagulation, which is perhaps a little bit controversial and slightly different to the directed therapy for COVID, but an essential part of our management protocol at Crudescure. So I think the first thing to say is that venous thromboembolism is actually a feature of severe COVID. In this recently published systematic review, which also pooled and meta-analyzed the data, including 42 studies over 8,000 patients, they reported and found that venous thromboembolism, so pulmonary emboli, DVT, thromboembolism at any site, occurred in about 1/3 of patients who were admitted to ICU with severe COVID. Pulmonary embolism occurred in 1 in 5 patients admitted to ICU with severe COVID. And the pooled mortality for all patients that had venous thromboembolism with COVID was 74% higher compared to patients that didn't have venous thromboembolism. And so clearly it's a complication and a feature of the disease and something that should potentially be targeted. And this is much higher than the rates of venous thromboembolism in patients without COVID from other studies. And so a number of observational studies have been done looking at the utility of anticoagulation or heparin use in patients with COVID. And many of these studies have suggested lower mortality. So on the left, this is a Chinese cohort, 450 patients, heparin use, not very well characterized cohort, but they showed a 20% absolute lower mortality if the D-dimer was more than 6 times the upper limit of normal. And on the right, this retrospective US cohort, including a lot of patients, 400 were ventilated, found that the overall in-hospital mortality with therapeutic anticoagulation was no different compared to patients that didn't get anticoagulated. But in the subgroup that were ventilated, there was a clear mortality benefit, 29% versus 62% that didn't receive anticoagulation. And in this large cohort study, there was no difference overall in major bleeding, or no significant difference. A number of other observational studies looking at therapeutic anticoagulation have been reported, and many of them have reported, a number of them have reported survival benefits. The top one here is a retrospective US cohort, all ICU patients. Most of them got therapeutic anticoagulation with a large survival benefit and a trend towards increased bleeding, but not clinically significant. Similar findings in a Dutch cohort, which was a little bit smaller, but all ICU patients. And in this large retrospective US cohort that didn't show a difference, it was a slightly different population and maybe less at-risk population. Half of these almost 4,000 patients were outpatients, and so had a completely different risk profile. In that study, there was no difference. Slightly higher rates of bleeding. These were patients that were already on anticoagulation before getting COVID, but not significant. Sorry, that confidence interval, that p-value is wrong. And then there's only been one small randomized controlled trial looking at the effect of therapeutic anticoagulation for COVID. And this was in Brazil amongst 20 patients only who were requiring mechanical ventilation. They were randomized to the standard dose of heparin prophylaxis versus therapeutic anticoagulation. And the outcomes that they were interested in was clinical improvement. And you can see here in the top panel, those with prophylactic anticoagulation on the left compared to those with therapeutic anticoagulation on the right. The ones that received therapeutic enoxaparin had a much better oxygenation over time measured by the PF ratio. And also more patients that were randomized to anticoagulation were liberated from being on a ventilator. And in this small study, there were no major bleeding events. And so recommendations across international guidelines vary. In general, UK guidelines are kind of more aggressive and suggest considering higher doses of VTE prophylaxis in patients at higher risk, which isn't really that well defined. Also, this international guideline does. US guidelines are a little bit more conservative, and one suggests standard dose. The NIH says that there isn't adequate data to recommend therapeutic anticoagulation or not. So we've kind of integrated this evidence and developed practice guidelines around it. And we've taken into consideration the very high rates of pulmonary embolus and DVT in patients with severe COVID, the mortality benefit that's been observed in observational studies, and now this clinical benefit in a randomized controlled trial. Also the observation that elevated D-dimers and obesity, which we see commonly in our patients, is associated with worse outcomes and may be predictive of pulmonary emboli in COVID. And then also this very important pragmatic reason that it's very challenging to screen and diagnose pulmonary emboli and DVT in patients with COVID, especially with severe COVID, who can't be moved easily because they're unstable, because the disease is dynamic and changes over time, and then also infection control issues. So these are our recommendations. In patients with COVID and hypoxic pneumonia, so milder hypoxic pneumonia, we provide prophylaxis with so-called enhanced dosing, and that's basically half the dose of therapeutic anticoagulation. And we provide therapeutic anticoagulation to patients with severe hypoxia. So those are patients with respiratory failure who would otherwise be in ICU and require high flow oxygen to maintain saturations, or if there's a very elevated D-dimer or a rising D-dimer, patients who have a clinical suspicion of venous thromboembolism, and but there has to be an absence of major bleeding risk, which we've defined, and we've also defined dosing. So there are multiple trials of anticoagulation underway, and really a difficult question is whether there's still equipoise. There might not be equipoise for providing higher doses of heparin to patients with severe COVID, but I think the key question is what is the right dose to provide? And it really is, I think, our responsibility at Hydrochloroquine to do an observational study to define the bleeding risk, but also for patients to get randomized to different doses in trials. So I'm going to conclude now with two main sets of conclusions. Firstly, as Linda showed, dexamethasone really is the only medical therapy that's been evaluated that has been shown to reduce mortality in COVID-19 pneumonia. And I've underlined pneumonia because dexamethasone doesn't provide a mortality benefit in patients without hypoxia. And there have been reports of practice in outpatients, mostly in private GP settings, where patients are getting dexamethasone infusions with mild COVID, and that shouldn't be done. Antivirals, as we've shown, I think, including convalescent plasma and anti-SARS-CoV-2 monoclonal antibodies, appear to work early before the onset of severe illness. And this has been shown quite clearly for remdesivir, and seems to be the case for plasma. Immune modulation, on the other hand, exemplified by steroids, seem to work later, and when widespread severe inflammation is set in. But immune modulation doesn't seem to work at all if it's too targeted. And we've seen that with IL-6 antagonists, and I haven't mentioned this, but the IL-1 antagonist Anakira was evaluated in a trial called Anaconda, but that was stopped early because of excess mortality. And there's going to have to be more nuanced approaches. Anticoagulation remains controversial and needs additional study. The second main set of conclusions is that large clinical trials are possible and essential in a pandemic. And this has been shown by Recovery and Solidarity. Just the very nature of these trials means that they can't provide granular enough data to understand how best to use agents. And so they need to be complemented by more detailed investigations, and there's still a place for randomized controlled trials in selected populations trying to understand the best use. The principle of equipoise should always guide decisions about off-label use. And the principle of equipoise is that it's unknown whether one treatment is better than another. And this is essential in order to encourage participation in clinical trials so that we can understand the best treatments for our patients with COVID. And then I just think this has to be laid to rest. Some drugs actually don't work, and hydroxychloroquine in particular is associated with harm, and these now need to be abandoned. And so finally, thinking about future directions, there's many hundreds of clinical trials you can see here from this network figure that are ongoing in COVID. I think it's essential to stop inefficiencies in drug evaluations for this infection. It results in duplication, lack of coordination. Linda's already spoken about the wastefulness of hydroxychloroquine, which I think has included in clinical trials, more than up to 9,000 patients, 22 trials, and has shown harm. We need to optimize the use of existing therapies. It's going to be very important to clarify the role of remdesivir, also to clarify and understand better the role of steroids. What's the best dose? How long should we give it for? And how do we manage glycemic control when we use it? A better understanding of the pathobiology of COVID is going to enable more nuanced approaches. And perhaps instead of targeting cytokines, we should be providing immunosupportive therapy. And then finally, it's going to be critical to understand and study interventions that can impact on longer term outcomes, not just 28-day mortality. We've already seen patients being complicated by lung injury and this phenomenon of long COVID. So I'm going to end there, and thank you very much to Linda, and thanks very much for the opportunity to speak today.
Thanks very much, Linda and Sean. That was an outstanding presentation. You've extracted out the key messages from the 17,000 articles published on the treatment of COVID, and provided us with some of the important highlights that inform our practice going forward. We've got time for just a few questions. We don't want to run too much over today. Maybe if I could ask the first question of Sean, and just ask, this issue around anticoagulation has been, there's been a question mark over it for the last 8-9 months, from the first reports of a high incidence of DVTs and pulmonary emboli. And it's just surprising that we've only got one randomized controlled trial with 20 patients. Why do you think it's taken so long to get high-level evidence on these issues? You have to be unmuted. I think you've got to push the...
No, I was blocked. I was blocked. I was discussing this with Peter earlier today. I think the focus has been on more directed therapy for COVID, and kind of less on supportive therapy, at least in randomized controlled trials. Also, I think that the ability to do trials for this have been disadvantaged and impaired by people like we've been doing, providing this as, as part of standard of care. And I think it's going to be very difficult. I mean, if we were approached in our hospital to participate in an RCT for anticoagulation, I think it would be a very difficult decision, just because we've now implemented it. I think those are probably the main factors. Yeah.
Okay, thanks, Sean. Mark, any questions from the chat?
So just a question from Robert Wilkinson. How can there be 170 ongoing trials in China when there's virtually no reported caseload? Sean, you want to address that?
Okay, now I'm unmuted. Yeah, Robert, I think when you look on clinicaltrials.gov, a lot of people that initially registered trials, and I think I might be a culprit of this, early on during the rush, just have failed to remove them or update them. And so I'm not sure if all those 170 trials in China are active. That would be my thinking.
Thanks. There's a comment from Dirk Long that patient X also takes rosuvastatin.
But isn't that for high cholesterol?
Yeah. Yes. Just noting your case presentation, Sean.
I think that's all the comments at the moment, Graham.
Okay, if I could just ask Linda one question. So Linda, the recovery trial is ongoing. Do you know what other important information we can expect from it? Is Linda there?
Sorry.
Yeah.
So currently, a couple of arms are still active within the recovery trial, as shown: aspirin, colchicine, and the monoclonal antibodies. I don't think with the current data that we're going to see anything further that is going to give us anything over and above what dexamethasone has given us in the recovery trial. Looking at the preliminary data from the smaller studies, as well as what Sean has shown with regards to the monoclonals that had so much promise. So I don't foresee that we're going to get any further outputs from that trial in terms of mortality benefit, the hard outcomes when it comes to these repurposed drugs for COVID-19. Sean, do you have any addition?
Yeah, and the aspirin arm was just recently initiated. Is that correct? I mean, so
yeah.
We're probably going to have to wait quite a while for that data. I think that's something that people are very interested in, because they have obviously been quite strong advocates for an antiplatelet approach.
Yeah.
And then, Wendy, there's just one other comment from Dirk there. He mentioned the statin because there is observational data that patients on a statin may do better. And that's people, as I understand it, who have been chronically on a statin and then are admitted with COVID. And as Dirk says, it's observational data, no trials to suggest that.
Yeah, that might relate to being anti-inflammatory, directing at cytokines, because we know in cirrhotics, in fact, there seems to be a survival benefit on individuals on statins, even if they haven't got non-alcoholic fatty liver disease. They might address the cytokines.
And as I emphasized, those are people who have been on it chronically, and it might not have acute benefit if it's initiated. It might be the effect on inflammatory cascades that precedes the COVID, or an effect on vascular health that precedes the COVID. Okay, Wendy, so there are no other questions, is that?
No further questions or comments.
So is it possible to put up the thank you slide? Just to say thanks once again to Linda and Sean. That was a fantastic overview. And we just wanted to spend the last few minutes just reflecting on the journey of these webinars over the last 8 months, and to say a few thank yous. So firstly, thank you to Sanjeev Arora, the director of Project ECHO, University of New Mexico, for expanding the license to run these webinars, to the presenters, and I'm going to expand on that in the next slide, for sharing their knowledge, as well as the panelists who joined many of the webinars. Sorry, can we go back? The panelists who joined many of the webinars, and to sort of get the discussions going, ask questions, and really share their insights as well. To the coordinators who've assisted in making the 20 webinars such a huge success, the 29 webinars such a huge success, and to all of you, the viewers and participants, for joining us each week and engaging in discussion through the chat function, really bringing these webinars to life. So we've got some stats. Wendy's collected some stats, and we've had over 11,000 attendances on our 29 webinars. Obviously, some of those are double counts and some of those are multiple counts. There might be one or two of you who've been counted 29 times, who've been on our webinars each time. But we know that there's been some very loyal attendees, and we're grateful to you. And those 11,000 people come from 47 different countries. So we really have had a wide reach from these webinars. You can go on to the next slide. And, you know, just to highlight the many presenters that we've had lab scientists, virologists, immunologists, hematologists, clinicians from many specialities focusing on COVID from the angle of their clinical specialities, public health specialists, people who are focused on research. We've had many speakers from South Africa, obviously, also speakers from the US, speakers from several European countries. We had one failed attempt to have a speaker from Brazil early on. And we're grateful to everyone for sharing their expertise, their time, to make these forums a really valuable learning opportunity and an opportunity for sharing and exchanging knowledge, as we've all learned about this condition and this pandemic over the last 8 to 9 months. Just to say that the recordings of almost all of the webinars are available through a link on the Department of Medicine website. And then just to say that we are intending to run more of these webinars next year. The exact format and time of that, we will give out information in the new year about that. And then just from my side to say a big thank you to Wendy Spearman and Mark Sondra. They initiated the idea for this expanding the ECHO license to run these COVID-19 webinars. They've done a large amount of work behind the scenes, and really thank you to them for also running the engine room and all the anxiety associated with that on a weekly basis. And I'm going to hand back to Wendy and Mark to say the final thank yous and wrap up for this year.
So thanks, Graham, and thanks really to Graham and Tobacco, who really took on the ECHO platform, seeing how it can actually disseminate knowledge and bring people together from very disparate regions. And as we've seen, we had 11,000 participants, 47 countries. And it really shows what one can do if one actually puts one's mind on it to actually disseminate knowledge in this way. So Graham, thank you so much. Approaching all the speakers, international, local, the panelists, getting us all to work together. And then importantly, if we need to actually really thank our supporting, so Department of Medicine, Gastro Foundation, University of New Mexico, and then really I think we need to just once again thank Mary Ann Davies and Andrew Gould, who've been really the stalwarts, introducing our talks every week and giving us updates, taking us through the highs, the lows, and maybe another low. And then importantly, Cheryl Valentine from Project ECHO, Karen Fenton from the Gastro Foundation, who've been very supportive in terms of actually getting the invites out. Importantly, Sahana Rangal, who has really been amazing in terms of revving up our invites and making sure the speakers come on time. And then importantly, Claire Jeffrey and Mohammed Johnson, who actually are responsible for putting the talks online on the YouTube and making sure that you all have ongoing access to these talks. So thank you very much, and thanks to Mark for keeping us in control here in the engine room. Thanks, everyone.
Thanks, everyone. Have a good, restful season, hopefully. Be well. See you next year.
Bye.